Our next topic. So we are moving on from the ventricle, and now we're looking at stuff that is what we call supraventricular rhythms or supraventricular arrhythms, because they're really dysfunctional at this point. So we're going to use the word arrhythms. So some of the things we're going to look at is pathophysiology of premature contractions, so premature atrial contraction, AV nodal reentrant, tachycardia, it's AVNRT, or just AVRT, which is AV reentrant tachycardia. We're going to look at junctional rhythms, atrial flutter, and AFib. We're going to be able to identify these on a rhythm strip. I want you to understand a little bit about what causes these supraventricular rhythms and basic treatments. So being able to identify, see them on the paper, on the rhythm strip, understand a little bit about, again, what triggers them, and be able to tell the difference between them. So when you talk about supraventricular arrhythm, it's any abnormal electrical activity originating above the ventricle. So this is going to be in the atria or the AV node or in the junction. A run of SVT, supraventricular tachycardia, is originating above the ventricle, however, not coming from the usual SA node, and the rates are quick, so greater than 150 beats per minute. We're going to take a look at AFib and A-flutter, atrial fibrillation and A-flutter. Really common is something called PAC. So we talked a little bit about this back in the atrium, but when you think about PACs, very common, usually pretty benign. If we were in the ex-phys lab, we'd usually see some students running or throwing some PACs with exercise. So atrial premature beats, sometimes abbreviated APB, or atrial premature contractions, APCs, also known as atrial ectopic beats or premature atrial complexes. It's a mouthful, right? All these different ways we can say the same thing. These are, regardless, it's a cardiac cell that's initiating a pulse. So it's any site in that atrium, is one of those cells is getting really excited and it's activating, it's firing before the SA node is stimulated. So when you have a cell in the atrium, we call it an ectopic site. An ectopic cell gets excited. It has the potential of causing a contraction without it being stimulated from that SA node. And this premature atrial contractions can happen in healthy people and diseased people. How do we know we have a premature atrial contraction? Is the P wave looks different. And we know it's the P wave because it's the atrium, and the atrium is what's causing the P wave on the EKG. Why does the P wave look different? Because it's not coming from the SA node, it's coming from an ectopic cell outside of that SA node. So another spot or site or foci within that atrium. So P wave is going to have a different shape, size from the usual sinus P wave. Sometimes it falls into the previous ST segment or the T wave, so depending on the timing. After the P wave, you'll see a QRS that follows. So like PVCs, it usually has a little compensatory pause, a little kind of pause before it goes back into the SA node. So here's an example of what a PAC looks like, right? So we have the sinus node firing, and then we have this early arising beat, which we know as that PAC. PACs can occur in different patterns, such as couplets, bigeminy, trigeminy, quadgeminy, and tachycardia, right? You've seen these words before. It's simply the pattern of which they're occurring, right? A couplet are two happening together. Bigeminy is every other beat, right? SA node, and then a premature, SA node, premature. Trigeminy is every third, quadgeminy is every fourth, and then a run of tachycardia is sustained. When we see a rhythm that has a series of cardiac cycles in pairs with the identical normal width QRS complexes separated by a consistent pause, then there's a really good chance we have something called atrial bigeminy, as long as there's no non-conductive P waves during the pause. If we have a non-conductive P wave, then we're going to be looking at the PR intervals, which is what we talked about before. The PR intervals, looking at AV node stuff, which would be indicative of that second degree AV block. Otherwise, if P waves are happening and they're, we're not seeing any issue with the PR interval, then we're not going to be looking at the AV node. So this is what we call atrial bigeminy. So it's every other beat, right? So every other beat is arriving too early, and you see that compensatory pause after that early, right? This is the early beat, pause, sinus rhythm. So that's PAC premature atrial contraction. Simply, again, this could happen on a healthy heart. It can be triggered by stress, caffeine, fatigue, electrolyte imbalances, different levels of oxygenation. Sometimes if treatment changes, such as stopping smoking, limiting caffeine, all of these, replacing lacking electrolytes, medicine, or they can go into the cath lab and they can do what we call a catheter ablation, where they can ablate the area of ectopy that's happening, that's triggering these ectopic foci to happen. When we look a little lower in the heart, that was the atrium. So now we're looking at PJCs, premature junctional contractions. These arise from the AV node, right? So this is different than the PACs. That was a site up in the atrium. So in PJCs, it's usually narrow, early, complex beats. It occurs when the SA node fails or becomes diseased. So if the SA node is not working, then that AV node needs to take over. And a lot of times we end up seeing premature junctional contractions happening to kind of save the heart, right? The SA node's not beating like it should. So what we see on the EKG is the P wave could be absent. It could be inverted. It could be what we call retrograde. As in the PACs and PVCs, it can also occur in pattern. So when you're looking at a premature junctional contraction, you're noticing that there's no P wave in the first complex. You're on the second, the arrow showing you an inverted P wave, an upside down P wave, and then interestingly, in this last one, the P wave is retrograde into that third. Either way, this is what we call junctional contraction. It's happening below the SA node. So what can happen is same causes that trigger PACs and PVCs. Plus, the big thing here is the SA node didn't ignite. It did not fire for the SA node. So a little lower in the heart, this PJC gets excited to try to get the heart to stimulate, to send some blood out of the ventricle. So oftentimes benign, heart rate around 40. It can get faster. We call that junctional tachycardia that can come on with pharmacological treatment. This is a picture of accelerated junctional rhythm. So what you're looking at here is very narrow QRS complexes. If you do a rate count just around low 60s, so we're at 63 beats per minute, and we are noticing no visible P waves. This is what we call a junctional rhythm. It happened below the atrium, but we're having the ventricle is contracting. So this is in the middle, right? This is the junctional rhythm. Something else that can happen is called SVT. This is supraventricular tachycardia. So we can take a look at what we're going to look at. We'll look at AV nodal reentrant tachycardia. We'll look at AV reciprocating tachycardia, atrial tachycardia, junctional tachycardia, atrial fibrillation, flutter. So we have a bunch we're going to look at, right? So first one is AV nodal reentrant tachycardia, AVNRT. Very common form of a run of SVT, right? What does that stand for? Supraventricular tachycardia. Common in healthy patients. We see it a lot in young women. Palpitations could be associated with lightheadedness, dizziness, shortness of breath, chest pain, pressure, activity intolerance, fatigue, and anxiety. When we see AVNRT, usually the appearance is going to be very narrow, complex tachycardia. It's going to have a short RP interval. And this reentry mechanism happens. So this reentrant circuit located within the AV node. So it's a very fast pathway and as well as a slow pathway. Again, triggered and terminated by different premature beats. So what this looks like is the AV node with fast and slow pacing. So we got that AV node, you got the slow pathway, you got the fast pathway. What this is going to look like when you take a look at your typical supraventricular tachycardia, you're noticing very short RP interval, rapid, regular ventricular rate, a normal looking QRS complex, but you notice no visible looking P waves, right? That's what's common, right? Because this is where it's being triggered, is below. AV nodal reentrant tachycardia, AVNRT, it causes, it can include factors such as basic factors of PAC. It can happen in normal hearts without, with regular sinus node timing. It could be patients who experience more frequent episodes as they age. Really, the treatment are usually what we call vagal maneuvers and adenosine. So that would be medicine by IV adenosine. And following the ACLS, so advanced cardiac life support for tachycardia, is usually what's going to follow. So pushing adenosine oftentimes can help that rhythm to go back into what should be pacing the heart. AVRT, right? So AV, reentrant tachycardia, is the second most common form of SVT in adults. We see it a lot more in children. So what happens is a bypass tract separates the atrium from the ventricle. And it's commonly, and you may know this if you know a little bit about some common congenital stuff with kids, it's called Wolff-Parkinson's-White syndrome. So that is kind of a type of AV reentrant tachycardia, or AVRTs, Wolff-Parkinson's-White syndrome. So what this looks like with congenital bypass tract creates a circuit for this AV reentrant tachycardia to occur. So so here we've got that AV node, and then we've got this bypass tract that's mediated, that's sending this reentrant signal to go back through. So the appearance with people with bypass tracts are usually what we call pre-excitement syndrome. Some will have normal sinus rhythm. Slurred upstroke of the QRS, which is a little confusing. It's called a delta wave, creating a wide QRS and a short PR interval. So wide QRS, short PR interval. Post-ablation, so if they go in there and cauterize and under a coronary catheterization, oftentimes the delta wave will go away and it's no longer present. So this is what I was trying to kind of explain, right? The delta wave indicating what we call a pre-excitement in patients with Wolff-Parkinson's-White syndrome before they have the catheterization. So again, looking at how that delta wave, the P wave, the QRS complex, and then post-ablation, after they go in there and fix there in the EKG, the delta wave is no longer visible. So just kind of the difference in how that firing happens. Congenital bypass tract is usually what causes this. Factors in timing of the conduction, reentrant mechanism, and again, most common treatment for somebody who has AVRT is going to be in the cath lab, an ablation procedure to try to slow down or help so the heart is not as active in sending these irregular tachy beats to happen. Atrial tachycardia oftentimes comes on when people are ischemic, so lack of blood flow, they have cardiomyopathy, congestive heart failure, hypertensive heart disease, ventricular hypertrophy, electrolyte imbalances, or really severe pulmonary disease. The treatment for atrial tachycardia usually is going to be metabolic issues. That's kind of what they're going to begin looking at. They'll look at what medicines are on, pharmacological therapy, usually going to be using calcium channel blockers and different types of antiarrhythmic medicines. And again, the big thing is looking at, in the cardiac electrophysiology study, so what cells in the heart are being active, overly active, and can they go in with an ablation, laser ablation, and kind of cauterize those areas that are overly excitable. AFib is really common. I'm always asking AFib question on quizzes because it's just something we see so often in cardiac rehab. So most common arrhythm in the United States, it can occur in healthy and diseased hearts, more common than what we see with so many. So octogenarians with longstanding hypertensive heart disease, potential life-altering complications from AFib can happen. What we oftentimes see are strokes, so an embolotic stroke or tachycardia-induced cardiomyopathy. When one has AFib, the atria is firing very sporadic, chaotically, and at a really fast rate, right? So what you see is, I always kind of, I don't have my camera on so you can see my hand signals, but it's kind of like a quivering heart. It's just quivering. And I was just like a fish out of water, right? It's just flopping around. The atrium is just quivering, and that quivering is causing a lot of chaotic ectopy. So lots and lots and lots of cells in the atrium are just firing. All these different cells are firing, and you get a really rapid rate. What happens when it's just quivering is clotting. The blood is hanging in that atrium, and it can clot. Ventricles are oftentimes contracting at a very fast rate, and it causes activity intolerance, shortness of breath, palpitations, diaphoresis, sweating, vomiting, nauseousness kind of feeling. The appearance on the EKG is the baseline of the EKG is really spiky, chaotic, irregular looking. You can't see any discernible P waves. Very irregular R to R intervals. Why? Because the atrium is quivering and the ventricle is not getting that blood flow out. So AFib can be paroxysmal, persistent, or it can be permanent. Those are three different types of AFib that can how it can look. So what we see here is this baseline. Kind of, you see that chaotic, it's not just a flat line, you see no P wave. Again, kind of strange looking, not really flat line, no P wave. So we see no P wave. We see an irregular R to R interval. And again, it's just quivering. That ventricle is, the atrium is just quivering. So whenever we see very erratic ventricular rate, we need to distinct and think, I want you to think, okay, this is AFib. And then try to decide if you see P wave. So why do I know this wave is, on the last slide, I'm going backwards here to this slide. Why do we know that this ventricular rhythm is irregular, right? Here's my ventricular rhythm. It's not happening in a regular cadence, right? So then I look and I see no P waves, and right away on the test I pick AFib because AFib has no P waves, no discernible P waves. Risk factors and relationships that trigger AFib are usually older age, advanced age, enlarged atrium, hypertensive heart disease, advanced pulmonary disease, paroxysmal or more frequent stress, fatigue, dehydration, excessive alcohol, caffeine, and recreational drug use. With AFib, oftentimes the treatment is going to be pharmacological treatments, anticoagulants to try to thin the blood. That is oftentimes coagulating and that sitting stagnant in the atrium. That's increasing the risk for the embolotic stroke. Is a common one. Pulmonary vein catheter ablation, permanent pacemaker. So the SA node, the pacemaker forces that pacemaker is igniting the atrium to contract instead of relying on all of these overactive cells. Another rhythm I want to look at is flutter. A flutter causes the same as atrial fib. However, in open heart surgeries with incision and scars in the atrium, patients often are having failed surgical procedures for AFib. Oftentimes it's going to be called that maze procedure. So patients decompensate more quickly with AFib, resulting in emergency medical situations. So very potentially life-threatening. Macro reentrant versus multiple micro reentrant circuits are a common thing we want to look at. So the appearance, instead of it being chaotic and no discernible P wave, how I'm going to describe the baseline of a flutter is what we call sawtooth pattern. So it kind of looks like sine waves, or maybe a steak knife, right? Those nice regular looking waves. The R waves may be regular or irregular, depends on the consistency of the AV block. So this is what a flutter looks like, different than a fib. So with a flutter, I call that a sine wave or sawtooth pattern, right? So that similar looking kind of sine waves that happen that are pretty continuous looking. So the treatment for a flutter could be less responsive to antiarrhythmic agents than AFib. Adenosine is usually used to push and slow things down, slow down the heart rate. Emergency cardioversion, so that's when they use the paddle, and as you've seen the paddles like on movies and TV shows, and instead of going all the way up to recardio, bring someone back to life if they're living with a flutter, it's a lower wattage to try to shock the SA node back into overtaking the rhythm. So it's kind of like shocking your car battery when it's not turning over. So a cardioversion is they go into the doctor's office and they lie down and they put the paddles on, and a low wattage will so-called shock the heart with hopes that the SA node beats back in. And if that doesn't work, they'll go in and usually do a cardioablation. So another rhythm we want to look at is pretty discernible. Discernible? I don't know. Anyways, you'll be able to figure this one out. But with supraventricular tachycardia with aberrancy, this is the 12-lead EKG, is going to help to distinguish what exactly we're looking at. So it's also, the important thing is to look at rate-dependent bundle branch blocks. So the treatment is not to be delayed. We really want to make sure that if the patient is unstable, we get them help right away. But this is what we're looking at, right? So this is very wide-looking tachycardia. This is SVT with aberrancy. Here is another one, complex wide tachycardia that can be proved with VTAC. So lots and lots of information about different types of stuff that happens that causes irregularity, what was supraventricular arrhythms. So we talked about the PACs, we talked about already last unit PVCs, now we're looking at different things that cause runs of SVT. The other important thing to go back and say, can you tell the difference between atrial fibrillation versus atrial tachycardia?